Hi, everybody. I'm Kathy Lord, and it's my pleasure to welcome you to, I don't know what number, but the monthly CART talks. As you know, we have distinguished lecturers pretty much once a month between October and June. And this lectureship is sponsored by the UCLA Tarjan Center, UCLA IDDRC, UCLA Brain Research Institute, and the UCLA Can Reach training program. So what's going to happen is I'm going to introduce our speaker. She will come talk. And then afterwards, we can take questions from Zoom, which I will translate for her, or questions from the audience. So it's my pleasure to introduce Susan White, who is the Doddridge Saxon Chair in Clinical Psychology and a professor at University of Alabama, Tuscaloosa. Susan is also the editor-in-chief of the ABCT series on implementation of clinical approaches and an associate editor of JCC, AP, and JAD. I have never met Susan until last night, but I've known her work for years and years, and she has been a leader in many ways. One was establishing really one of the very best graduate clinical psych training programs in autism at Virginia Tech. She has now moved to University of Alabama. Well, she is doing the same thing. So those of you who are interested in graduate training, it's like a real live autism focused person in a psychology department. She also has led the way in terms of research with adults and older adolescents, and was doing this long before anybody else or many other people was doing it, and combining this with not just phenotyping, but intervention research. So she's brought us all along and into the future. And today she will talk about the transition to adulthood. Thank you, Susan, for coming.
Thank you. Oh, gosh, watch yourself there.
Yeah.
Okay, I'm really hoping I don't trip on the many cords around me that the people on Zoom can't see. It's very scary up here. And thank you for having me. And thank you all on Zoom for being here. I'm going to hope my technology holds out here. Today, we're going to be talking about supporting autistic people during the transition into adulthood. I want to share my own positionality in terms of my space in this research landscape and my disclosures for current funding and royalties here. First, I just want to show gratitude for you all having me here. I know you are exceptionally busy people, and this is kind of scary for me. I've been doing this for a minute, but you know, I've kind of like Kathy Lord has been kind of like a rock star to me, and I did not ask her to sign my neck last night at dinner. So I'm glad for that. But thank you for your time. This is the agenda: helping and embracing the value of helping while embracing the value of neurodiversity, what it's like to adult on the spectrum, how to support during the transition into adulthood. I'm going to be talking about the STEPS program that I developed and sharing with you some of the research from that, and then the next steps in this domain. All right, so just a few slides here on that first of the 4 agenda items. I think that we need to be thinking hard about how we help, okay? Because just that word, there's a lot packaged into that when we think about a person with who identifies as autistic or neurodiverse, and what they want help with is often not what we necessarily have the skills to help with or what others in their lives want help with, right? So helping and embracing the value of neurodiversity. So moving beyond this tolerance mindset. On the screen right now, you see some quotes from autistic people and one parent of an autistic teen. I'm not going to read these. You can just take them in for a moment, but I want to share these with you. They're just from patients in the last year, because what we see is this struggle of getting by in an holistic world that's not necessarily built for their way of functioning, their needs, their challenges. Now, as Kathy alluded to, a lot of my career has been spent trying to better understand the landscape of comorbidity, specifically co-occurring mental health conditions among autistic children, teenagers, and adults. These data come from, I'm sorry that it's progressing on its own, little ghost. Many labs. This is not just, it's not my epidemiological data. Most of this is not epidemiological. Okay. A lot of it's slanted toward clinical samples, but I want to draw your attention to how high many of the prevalence estimates are, especially for conditions that you might think are rooted to some degree in emotion dysregulation difficulties. Okay, aggression, hostility, not a DSM or ICD condition, but it's part of many conditions, anxiety disorders, depression, suicidality, and self-injurious behavior, especially. But this quote is especially poignant when we think about adulting on the spectrum. I'll read this one. Due to his inability to manage his emotions and communicate, he attacks us when he becomes agitated or stressed. This behavior is very unpredictable and often occurs with little to no warning signs. It's happened at our home, his school, in the community, and sometimes while driving a car. It is so bad that we can no longer safely live in our home with Ryan. This is one case example, but I think from the facial expressions and from other clinicians I've talked to, this is not an atypical experience for what it is like. So it's embracing the neurodiversity, respecting the person's goals. I'm not sure why my computer keeps doing that. I'm going to try to mute it. But then also recognizing that this individual lives in a broader social landscape where there's also safety concerns and other family members often or people in the employment setting. So bottom line, when we think about the challenges adults on the spectrum face and what it's like to adult on the spectrum, it's really a matter of your point of view, your context. Okay, you've probably seen this figure before, right? It depends if you're looking from the inside out with like the lived experience, and your lived experience is not going to be like whoever's sitting right next to you, but also from the outside in. And we all live in this bigger society, and that part won't change either. So what does it mean to help an autistic person? Y'all know what these figures are? These pictures? Maybe. So like autism has this beautiful and horrendous history of trying to treat the condition. What's that?
Figured out what one was.
So just a few examples here. Secretin therapy. Okay, if you're familiar with secretin therapy, it's trying to basically fix imbalances in the gut that are thought to or were thought to create a lot of the behavioral difficulties that we see in autism. There's really no evidence to support it, yet a lot of money has gone into researching this. Chelation is another treatment. I don't know if people on the West Coast are still seeing this. We certainly are. Okay, in terms of removing heavy metals from the body, they're very dangerous. ABA, with use of aversives like shocks or withholding of food or other incentives, there's a lot of backlash. And I understand why that is, of how humane is this approach to treatment. Something might be effective. That does not mean it's necessarily socially valid or what that person wants. Facilitated communication. Does this one ring a bell to people? Okay. Has largely been debunked, but it keeps recycling. Rapid prompting method. Have you seen this lately? It's facilitated communication. Okay. So approaches to aid the nonverbal person to communicate, but sometimes not necessarily their own thoughts, their own communication intent. All right. So is clinical care and rigorous research antithetical to a goal of embracing neurodiversity? I don't think it is. I don't think it is. but we're going to have to work at it. Okay. Oh, my neat little animation. I want to get that to work. So kind of our field right now, I view as very much this pendulum of fixing, not fixing, disorder, not disorder, more like a personality or a characteristic of self. So you might assert on one end of this that autism is a different way of being. It's not a disability. It doesn't require treatment or fixing in any sense. But then on the other hand, what do you have? People that you might call like having profound autism, right? People who are severely impacted and not able to get by in their day-to-day lives. And this is the spectrum that we're living with right now. This is not new, but it's really hard for clinicians and scientists to think, how do we treat this condition when it's just so vastly different across people? So to summarize, when we think about adults on the spectrum, I would say this: the focus is not on curing or even treating the autism 90% of the time or more. It's rather about optimizing quality of life, largely as subjectively defined by that person, and helping them have voice, have a say in the treatment that they need, and helping them kind of get by as best they can in this society that we have. And that's largely how we do that, is targeting quality of life and mental health. And that's why I was bringing in the mental health component earlier. Okay. All right. So now I'm going to talk for just a couple of minutes about what it is to adult on the spectrum. Okay. I have 4 slides here, and these are not specific to the STEPS program. That's going to be the bulk of the talk. But when I'm working with patients or when I'm training students who are going to be clinicians, these are like the 4 areas where I say, this is what you need to focus on, because no matter what treatment you're doing, no matter what the problem that you're targeting, you have to think about these constructs for adults on the spectrum. First is motivation. Okay. It's hard work. It was hard work for all of us to get to be adults, right? Probably some of us are still facing struggles on a daily basis. And it's a choice, right? Like you think about like exercise or reducing your calorie intake or whatever the thing is that you want to change. Like we can't just say, oh, I don't feel ready. Like, and that's, it's not a feel. It's a choice. It's a very volitional thing. And it's the same kind of concept. It draws a lot on motivational interviewing for substance use disorder when I'm working with adults on the spectrum and helping them understand, yeah, you've got a choice. And this is a dialect. And there's going to be days where you don't feel like doing it. And a step back doesn't mean failure necessarily. Um, and there's so much that goes into this of like helping the parents slowly start to let up. Okay. And let the person experience some failure, some strife, and creating a vision together of what it might look like to have their young person no longer be living with them or under their wing or financially dependent. Whoopsies. Second, so motivation. Second is client buy-in. I have found as a clinician, this is something that I have to do more so with autistic patients than with non-autistic. So being very explicit on showing them where change is happening. Okay, so taking data more regularly, making sure that their goals and objectives are realistic and really well articulated and defined, and that I will be able to, as a second party, as a proxy, be able to point out changes. And really, you know, a Carol Dweck approach of like rewarding, praising the effort that goes into it, not the product, because sometimes it's the effort, the things that don't yield that much of a product can take more effort in life. I love this quote from Denzel Washington, and ease is a greater enemy of progress than hardship. Usually in therapy, if it really sucks and it's really hard, you know you're doing something right, because otherwise you wouldn't be coming here. This is not a spa. Third, gaps between systems of care. This is something where you have to almost put on like a social worker or case manager hat, because there's gaps in every which way. when you're working with adults on the spectrum, whether it's in research or in practice. There's a disconnect between IDEA, the Individuals with Disabilities Education Act, and ADA, right? In terms of your legal rights, your protections, accommodations in the workplace, huge gap. And there's almost no guidance on how to navigate that gap or work within your rights within the Americans with Disabilities Act. Second, you have a lack of engagement from the entities that are needed to support these people, like your local employers. In most states, you all know California better than I do, you have a huge disconnect. I know we do in Georgia and Alabama, but between the DD system of care and mental health. So you have this for, I'm sorry, it's a crass term, but punting of patients of, I can't take that, that's got to be over here. Or clinicians who say, I don't work with people on the spectrum. And then so many issues with people who can't find stable employment and covering services. Okay, the fourth and final is the lived experience of autism. I think it's really critical that we all kind of take time when we're getting to know the person's identity and help them understand all the facets of their identity in terms of the language that they choose to use. This is not just like a gender identity thing. This is also an autism identity, and to what degree they own this diagnosis and what it means to them. Okay. To close out this section, this is work I've been putting a lot of my own time into. I think that it's really important to not just accept neurodiversity, but to embrace it. Okay. And to help other people see the value in this. So our job isn't to fix a problem necessarily, but to help another human optimize their own quality of life and to reach their potential. And we do this by understanding and appreciating the intersectionality, if you see here, the intersectionality of their own identity, their own diversity, and helping coordinate within a highly disjointed system of care in which we all operate right now. Okay, as caregivers, as people who care, as clinicians, and as researchers. And finally, honoring the client's personal goals and not letting those be clouded out by the goals of their loved ones, by their parents. We can take it all in. It doesn't mean that they necessarily have to align. So these, I think, are the three stools, if you will, of how we can optimize quality of life for these individuals. Okay. I'm going to move into now the STEPS program. This is a program that I have spent the last 15 years or so working on, and I'm going to describe the development of STEPS in some detail and present some current research on how it's impacting right now. So what got me like at the crutch of all of this is strengths-based thinking and not taking a deficit model of autism. And I think this is something you all are probably very familiar with, okay? But identifying first and foremost in a positive psychology approach, what are the strengths of this person right here in the room, and how can I work with that material, that raw material? The development of STEPS. I used the orbit model, which you see on the left, and an experimental therapeutics model, which is on the right. The orbit model is essentially a stepwise approach to how you start small in a clinical sense to detect an indication that you're making an impact on the target process, okay, or your outcome of interest, and then you work from there. Experimental therapeutics is essentially you look at change on a proximal process that's thought to underlie downstream effects in some type of clinical phenomena or problem of interest. Okay. And this is, you know, for anybody that's not been living under a rock, but NIMH has been pushing now for over 15 years. So when we think about the orbit model, the initial development of STEPS, this is what we were working on. So preliminary focus groups with young adults on the spectrum to develop the very first alpha version of the curriculum. We piloted this in a group of just 8 people, 8 young adults on the spectrum, and we compared it to a brain-computer interface. So we used EEG I wanted to be maximally different from what we were doing in steps. Okay, so the same dosage, same frequency of sessions, same length, and the same amount of human contact, but targeting a different process, if you will. We had no drops. Everybody went through promising outcomes, but you can't really make too much, you know, when you've got 4 per condition, but that's the point of the orbit model. You're trying this on a very small scale first. So then we're moving around here. If you can, I'm not sure if you can actually read the font here, but the red here says now we do a mixed methods needs analysis. So this is a series of 3 studies, qualitative, quantitative, mixed methodology, where we did focus groups, which if you can envision 3 different stakeholder groups. So people on the spectrum, those who are affected, caregivers, and educators at the secondary and post-secondary level, to try to understand what are the challenges that this population faces. What do you think we could help with in terms of the goal here is successful transition to more independent adulthood. And spoiler alert, the punchline, okay, if you actually don't want to get these articles, is it comes down to 3. We had a very high degree of convergence across these data sources, and this included nationwide survey sampling. It's self-knowledge, self-determination, and self-regulation. These were the 3 processes that, if you will, these 3 stakeholder groups identified. This is like where most of the challenge in this domain, getting into adulthood, lies. And I mean, it's not like not intuitive. It makes sense. So for self-knowledge, we're thinking of things like what do you think of your diagnosis? How does it impact you? What do you need help with? It's almost like what a person should theoretically be doing at the age of 14 when they have an IEP. But most people don't necessarily do that, all right? Understanding, what do others see in me? What do I see in myself? How do I ask for help? Self-determination is more of this, how do I ask for help and assert myself, okay? And know what my goals are and develop a plan to get to those goals. And then finally, self-regulation. This is a lot of stuff, okay? I don't think these 3 concepts or processes are equally weighted. Self-regulation is things like emotion regulation, coping with stress, executive functioning, time management, etc. And this is where we pull back in that figure on the bottom left, the experimental therapeutics approach. These are the 3 target mechanisms. Okay. All right, so then we have all of this data. I went back to the drawing board and revamped the curriculum. And I sent the manual in its beta version to a bunch of stakeholders. So experts in the area of autism and working with adults on the spectrum, clinicians, parents. I had 2 people on the spectrum review the curriculum and give feedback. Is this logical to implement? Would you be able to do this with your patients? Is this offensive? Does this make sense to you, the language? And they provided really great feedback on this, and that led to the RCT. This was an R34 funded RCT with 59 people. I know this is a horrible slide, forgive me, but I always feel obligated to show the consort for some reason. I'm not sure why. We had high acceptability and high fidelity. But I think what's more interesting here are these 3 target processes here, okay? The mechanisms that we're supposed to be moving the needle on in steps. What we see here, and I show the arrows for self-knowledge, self-determination, and self-regulation. We saw significant group differences in every process. Okay, so statistically significant and moderate to large effect sizes in this trial. If you're wondering here, the TAU is transition as usual. They got whatever services they normally would. We didn't provide them, but whatever they would through their IEP, and we tried to monitor that, or through like what they were getting in the disability support office. Not all of our participants were in school of any kind. So it was kind of like a mixed bag there. All right. So does this slide look familiar to you? What are we talking about here? I know some of you know this. Implementation science, right? Addressing that gap between what we think we know and what we actually do, or what's happening in the community. So this is where my headspace is right now, okay? I am a big follower of Curran's work and different types of hybrid trials. In a nutshell, what Curran has taught us is that there are 3 types of hybrid trials that vary on the relative weighting of the degree to which you focus on clinical effectiveness versus implementation, or those processes that impact the treatment's potency in real life and provider and other variables that need to be addressed to optimize impact. Okay. All right. So I'm going to show you very quickly 2 types of hybrid type 1 trials. Hybrid type 1 focuses primarily, like normally the first aim is on clinical effectiveness, and then secondarily looking at these implementation processes. Okay. So this is my current team for an R34 that we are just entered last month, the 2nd year of through NIH. These are some of our community partners throughout the state of Alabama and then northern Georgia. Okay. In the, I need to back it up for a second. So before the R34 was funded, we got a small award from the Organization for Autism Research to run an open trial in the community with community-based providers. And this was the first time that STEPS was run outside of a research setting. Okay, so we couldn't provide any supervision. These were licensed providers who were willing to let me go in and train them and then basically fly free. All right, and this is really scary. Okay, it's kind of like pushing your child out to college. All right, because you're saying, well, good luck, and I can't monitor you anymore. And that's oftentimes where we see in implementation science, this voltage drop or this like loss in potency or effect. So in this trial, we first ran a series of 3 implementation work groups with people in the department, Alabama Department of Rehabilitation Services and the Alabama Department of Mental Health, insurance panels, providers, and a couple of agency leaders to try to get input on, just sustainability. How do we make sure that if this thing is successful, that people will actually use it, for instance? And then we went into the open trial. The primary outcome measures in this open trial were the reals. This is a measure of Carla Mazevsky and Sean Eek, looking at relationships. It's called relationships, employment, autonomy, and life satisfaction. It's meant to be used for autistic adults, okay, in terms of treatment trials. And it's a compilation of scales that tap a lot of different areas. So what we see on the top right here is the reals frequency of engaging in financial tasks. This was a self-report scale from the autistic patients in the trial. And we see significant change in the self-report data, but not in the caregiver report data. Okay, so like this was just run last week. I'm not sure what to make of it right now. I have a lot of different hypotheses. Yes.
What is the general IQ of these participants?
That's a great question. For people on Zoom that may not hear that, audience question was, what's like the general IQ functioning level of the participants? In that first trial that I talked to you about, we restricted to no participant had confirmed intellectual disability. The IQs went down, I think, to 68. Okay, on that one. This trial, we took everybody. Okay, so there's no restriction. We did have some very minimally verbal people in this trial as well. And then transition readiness, we see a significant change for the self-report and the caregiver report data. Change in target mechanisms. So there's 3 mechanisms. You got them imprinted in your brain now, right? Self-determination. We see significant improvement in both self and caregiver report. And you notice I don't have the comparison group because we're still talking about the open trial right now. There is no comparison group. Self-regulation, what you see on the screen is the EDI, the Emotion Dysregulation Inventory, which has 2 scales, dysphoria and emotional reactivity. On the reactivity front, marginal improvement for the caregivers, no significant change for self-report. In the dysphoria scale, marginal improvement for the caregiver, significant improvement for the self-report. And then finally, self-knowledge, no significant change on that. Okay, and I want to say this sample was 22, if I'm remembering right. So pretty small, but that doesn't look to me like, well, we'll see. Not feeling very hopeful right there. And then finally, this is the second R34, that's the hybrid type 1 community implementation trial. Here we are targeting a final sample of 80 participants. We have 21 providers enrolled, 2 conditions, okay? We don't provide any supervision or ongoing training of these people. The training has already occurred. And now they're implementing basically active control. So whatever therapy they want to do to address the person's needs. And we have truly got a range of other therapies, okay? Some of them are very good therapies. Some I'm like, I question sometimes, but this is community implementation. So this is where we are with the consort. I can't share with you anything because we only have 17 people through endpoint across both conditions, and we've got nobody through the 6-month follow-up on this. So this is where we are. So cliffhanger on that. I'm going to share just a little bit of information on what STEPS is, okay? This is a 16-week program. It's meant to be delivered in weekly sessions, which is what most clinicians prefer and what can be billed usually. 1 hour per session. We have 2 immersion activities. These are meant to be community-based sessions where the person gets a chance to practice the skills that they're learning with the help of their therapist in the program. They have regular check-ins to make sure that they're kind of on track and doing the work that's being discussed in the program. And then there's a caregiver workbook because I felt really strongly that I didn't want to have the caregiver in the session whenever possible, because this has to be client driven. Put them behind the steering wheel and they can choose how much they want mom or dad. That's usually the caregiver involved in this. These are the sessions. They can be repeated as needed during the length of the program. I'm going to just talk about a few of these as exemplars. In the second session, we talk about goals clarification. When I'm training providers, I'm really clear with them. You'll see at the bottom bullet here, those target processes that are targeted in each session. So here we're talking about, just like a few slides back, making sure that their goals are very realistic, that it's something that can be attained. It's great to have 1 year and 2 year goals, but not in the context of a 16-week program. So oftentimes it's, okay, that's a great goal, hold on to that. What can we do toward that, like a step toward that in the next few weeks together? Managing intense emotion. Okay, if you've done CBT, this figure probably looks really familiar to you. So building awareness of emotional states without much of a focus on labeling discrete emotions. The big focus here is on kind of respecting where the client is, okay? And that sometimes adulting is really hard and you need to know when to be easier on yourself and stepping back when you need to. So it's addressing masking and burnout and emotional awareness. And then finally, self-advocacy. I think this is one of the more fun sessions. This is where we talk about things like just how do you know when you should disclose your diagnosis with like a potential employer or a mate, somebody that you just started dating. And so usually when I say that, I get a question of, so how do you know? And it's not, there is no answer. There's no blanket answer on this. It's more of just think about it in advance, because I will bet you $100 you will face this. And so you need to know, at what point do you feel comfortable and how much do you share? Okay. And that's what we work with the clients on, is knowing their rights legally and also their responsibilities, speaking up when they need to, asking for supports that they need, and being able to explain the disability to the degree that they want to, or their diagnosis. And then the immersion. So I would say, in terms of the qualitative feedback that we've gotten so far across these 3 trials, from the caregivers, the therapists, and the patients, what's the most important thing to you? What helped the most? It's the immersion. Like, this can't be done without like feet on the ground practice. So the immersion is meant to be some activity that's personalized to what the client's goals are, where they have voice in how it goes. This has been all sorts of things. Okay, there's 2 immersion activities during the course of the program, and it's things like making a grocery list and going to the grocery store on my own. And I'm going to have to do like the price per unit and do my comparison shopping. And a lot of people, even when they're like 25, they haven't done that type of thing before. And to be able to have a sense of success of like, I didn't have to have my mom there. We have done almost like a driver's ed, which can be really tricky with people because a lot of our clients have really struggled to get their permit or have failed multiple times on their road test. And it's not necessarily that they don't have the skills, but they get too aroused, too anxious when they go in there. And so our next step on that is going to be working with the state DMVs to have some satellite offices where they know how to work with people who are neurodiverse and people on the spectrum of, well, are there any like sensory issues that we can address? How can you give them more space, more time? Maybe allow a parent to go back with them for a couple minutes before they start the test. So I gave here some examples of the types of things that we do on immersions. These are not prescriptive. We really encourage the therapist to be creative on that. Next steps. Okay. So here's my big 3, and I'm almost done. In the coming months, I'm going to be publishing the STEPS curriculum. And the goal here is to work with, again, this is from the implementation side of things, and I fully credit Curran for this. It's like you can't build it and trust that people are going to take it. So what I have learned from working with the stakeholders on this is that we have to work through the schools and through voc rehab largely. So we're going to be training the voc rehab providers in the state, as well as some school districts on how to implement steps in the secondary schools. I'm probably going to have to use a group format, which we haven't done. I think we need to connect across these different systems of care, like developmental disabilities and mental health service systems, so that we don't have basically unfair treatment of these patients. Okay, and they are, it's hard enough to get them into the door. And then when they have to go out that door and find, okay, now where else do I go? And it's also not fair for their caregivers who have been doing this their whole life, kind of acting as case manager, to have them do it. Second, I think we need to look at subjective quality of life indicators and community functioning. I think for me, quality of life is the North Star in any therapeutic approach for an autistic adult, of what would make you feel satisfied, what would make you be productive in this life that you've got. But again, like I said in the very beginning, we all live in a collective, in a society. And some might argue that we all also have an obligation to contribute to the greater good. Okay, so I think for this, there is this balancing act. It can't be all just subjective, but it's both. And then third, building flexible delivery models. So like I said, we're looking at group delivery. The last 2 trials have been a mix. Okay, it's client choice if they want it virtual or in person. Shorter sessions, longer duration, like over the course of a school year. So that's where we are right now. And I like this quote even more. Lord gave me coffee to change the things I can and wine to change the things I can't. Because I feel like a lot of times when we're working with this population, we know that it's a huge task, right? But it's like, you know how you get through the elephant or the whale, whatever your analogy is, it's like one bite at a time. So I hope this was useful to you. I really appreciate your time. My email is there, and I'm so happy to hear from any of you after this. So thank you.
Thank you, Susan.
Thank you.
That
Thank
was
you.
Wonderful. So questions. We'll start in the room and then go to Zoom.
What adaptations, if any, for those who are more minimally verbal or higher support needs?
Yeah. Julia, is that right?
Juliet.
Juliet. I'm going to repeat the question. Is that okay, Kathy?
Yeah.
I don't know if people on Zoom can hear. So that question was adaptations for people who are less verbal, right?
Higher support.
Okay, thank you. Okay, that is a really great question. And that's like what I'm in the throes of doing in the manual revision for publication right now. But the biggies that we have found is slowing down the pace, and we're often then having to bring in the caregiver more into the room. And the third is more use of visuals. And this is one area where I actually kind of prefer sometimes the virtual delivery because you can more readily screen share things and pull them in. On the flip side, sometimes we've got patients who have more, what I would say, symptoms of ADHD, where it can be really hard to kind of keep them engaged when you're in a virtual format. So I think it can be done. And the reason it works, I think, for steps is it's not just targeting like college readiness or that type of thing. It's whatever your outcome is, whatever your goal is. So thank you.
So we'll let Dan has a question. That's what she said.
Oh, okay.
Dan, yes, right.
On Zoom.
Yeah, hi. No, thank you very much. Sorry, I'll be seeing you later in person, but for a number of reasons, I couldn't get in. So but I've been here in the ether. Really interesting talk, and it's so far out of the area that I work in. I work in genetics mostly, and so I'm really. It seems to me, and I loved your last point about alignment, right? Alignment of these different services from different agencies is really an essential problem. And, this may be too existential for you to answer, but how do you see us aligning the incentives of these agencies and things to work together? Because the way I see it, their incentives are to not work together, to kind of like push off one thing to the other. In countries where there's a single payer system for education, health, and where the government plays a bigger role and kind of organizes all of these things, of course, the incentive is there to save a lot, for everybody to cooperate. It saves tons of money and works better. Here, it's like the health system wants to push it off onto the school system. They want them to pay for it, and vice versa. So, in the early times, and as in adults, there are all these different agencies who are funded through different funding streams, and yeah. So does that? Yeah, is what I'm saying making sense or to you? Or?
Sadly, yeah. Yes. Can people in the room hear that?
Yeah.
Okay. Thank you so much for that question. I think Kathy wanted to answer it. I'm joking. I agree with everything that you just said. I don't like the answer that I'm going to give, but this is where I've been forced into. In my other work and in other trials that I'm running right now, we are relying heavily on patient navigators. Are you familiar with navigators? Okay, so this came out of breast cancer
of course.
research
Yeah.
years ago.
Yeah, no, we use them all, in a lot of
And it's almost like helping a person who's lived through the trauma of working the system to help other people navigate the systems. And it's just not, and why I hate my answer is it's not fair. Like, I feel like that's not the way it should be, so to speak. But yeah, like our country is just, bottom line, we are not doing good on that. And you're right. Like I'm not, it's above my pay grade to know all the reasons why that is.
I mean, I think honestly, even countries, even Scandinavia divides things up from mental health and developmental disabilities and medicine. And so even the very best places pass things back and forth. When you're lucky, you get them working together. But it's, it's probably, we need the org guys
Yeah.
to come in.
But I do
tell
think
us.
one thing that might be specific,
Mhm.
more specific here is also how the insurance works and
Yeah,
what's
that is
allowed billable across private
Yeah.
insurance and public insurance
Yeah.
for people on the
Yes,
spectrum.
that is, I completely,
So we have had to work hard to bill this basically under mental health codes as
Yeah.
CBT.
that's,
Yeah, so I guess, the question is for us, like, we do get occasionally called or get to interact with, political, people who have political power in a way. I mean, I'm thinking it's something we should think about in terms of what message we need to give them, kind of a very simple, kind of clear message. Because it seems like it would save a lot of money too, right? Like when you do things effectively, it always saves money. I mean, have you, yeah, I mean, maybe this is outside, I'm asking but as academics, we publish stuff and we come up with this stuff. And then there's all this difficulty, as you pointed out, society implementing things. I mean, in the area you're talking about, there's so much need for research and academic work in here because there's so little known. So that's one piece of it. And the stuff that you've been highlighting is seems to me to be kind of essential to know. I guess, so I'm not, believe me, I'm not downplaying that at all. It's like a critical thing, but like, I'm also, I also kind of hear as you're talking, these other issues, and I'm wondering what your experience has been. Like, have you had any even small successes in pushing that forward? Do you have any advice for us?
Like on a micro scale, okay? So like where I've had the most movement is talking to our state agencies. So State Department of Ed, state voc rehab, and state mental health. When I can get the players in the room at the state level, it works better because I think they're all like smart, logical people. But you're right that the incentive structure isn't there right now. It's almost like we need to link the dollars to it. And I hate to say that. But like the only way I think to shape policy is to show black and white. Like, here's the dollars that you're wasting on this. Is that if I can just really quickly, the other thing that I think if I can enlist more people into this, what we're trying to do now is not on the research front, but on the policy front is help employers in the state. And I'm not just talking about like the goodwill employers, but we might have like a more career of what are your, how could it help you from a legal sense, from a monetary sense to bring in people who are neurodiverse. And we're actually starting to get traction on that front. But the only way, because I was trying to do this for a couple of years on my own, I was just not doing well. But how it worked is partnering with people who have been successful in like not academia, who can communicate with these individuals and like, okay, you really got to talk the dollars and cents. So I think sometimes it's getting out of our comfort zone, I guess, getting out of our own way.
Thank you. I'm sorry. Yeah.
Thank you.
So let me ask the one Zoom question so far. What does it mean for caregivers to be ready for a transition? I'm curious about this outcome measure.
Yeah. Okay. So the transition readiness scale, spearheaded by Rebecca Elias, who actually worked with Kathy Lord a couple years ago. I
Is that USC?
don't think she is. Yeah.
She's here.
Whoever wanted that, if you email me, I can share the measure with you. But what we are looking at is across cognitions, emotions, and behaviors, the readiness to live independently. So it's everything that we were talking about in terms of those key processes. So managing your things, your time, planning ahead, etc. It brings in some executive functioning capacity. But if your question was more about therapeutically, a lot of times a lot of effort has to go into working with the parents because we have indoctrinated them into be everything, be the everything for your young person on the spectrum, because nobody else will. So you have to be their treatment provider, their case manager, and it is really hard to let go of those roles. And I don't think that's just the case for autism. It's ADHD, it's learning disabilities, because nobody's going to advocate for your kid like you will. And so helping them start to let go of that.
The data that you've shown where the big discrepancy between caregiver report of improvement versus participant report of improvement.
Yeah.
I was just curious to know more about that. I think if are there sort of items that you saw that maybe did hang together? I understand it's recent data. And why do you think you saw that discrepancy?
That is one question that's excellent. It's basically, why are you seeing discrepancies between the self-report data and the caregiver report data? And like literally this was like 4 days ago that I was working on these data. So if I answered right now, I would totally be guessing. I think, and I guess I will guess, I think it's partly that you're seeing a difference when people don't live with their parents and when they do. Okay, because there's no requirement here. A lot of our participants are living elsewhere.
But I actually, just to put in a plug for you, there is a paper that was a group effort from the Journal of Child and Adolescent Psychology about multiple informants,
Yes.
which is wonderful, you guys. And I think talking about the importance of what do you do with these different pieces of information and what do they mean? Because I think it really is, it's just, I mean, which Susan was involved in, but which it really outlines like, what could it mean? You know, and very organized, because I'm probably more skeptical about the autistic adults. I mean, I think they do know, I mean, they are speaking for themselves, which is really important, but there are different perspectives, and we have to be careful to include them. And some of it maybe parents don't know, but sometimes parents are
Right.
more accurate about somebody's actual, what they actually do than a person. And probably my mother, if she was still alive, would be more accurate about me in certain circumstances. Anyway.
And I think the difference between what they do and how they feel and
Yeah.
the quality of life piece is also very important though. So if they feel like things are getting
Yep.
better, isn't that also valuable?
Yeah.
So it's,
Right.
even if it might not look like it
Yeah.
in a traditional sense.
So getting that information
Yeah.
seems really important for both of them.
So the
There's-
question for Zoom people was
Yeah.
basically just talking about, especially for quality of life, that we really have to consider self-report.
And then probably a quick question. Dr. White, thanks so much for sharing your thoughts.
Thank you.
How accessible is STEPS now, and do you have plans for expanding its reach? It sounds like your book.
Yeah. So I'm happy to talk to anybody, and I've trained a lot of people now on using steps. It's hard to predict, books move at a glacial speed. So I don't know if it'll come out in 2024, maybe, but probably not, just from past experience.
So email her.
Yeah.
Just what you need, another email. Or somebody else in the audience who wants to ask?
Well, I was going in that same direction. So I'm like working in community mental health, like dealing with some of these exact issues, like all of these issues you brought up, both like how do we treat autism in like mental health circumstances? How do we help these families support their kids in the transition to adulthood? So I'm so appreciative of this, even to see how important it is. And yeah, I guess I wanted to know, like, if I want to get trained in this, if I have other people who want to get trained in this, like, how do we do that?
Yeah.
Get training.
Expansion on the question of like for community-based providers, how does one seek training? Okay, first off, I should say like, this is my baby, but it's not the only baby. Okay. I trust this baby. I put a lot of time into the program, and I don't know right now that there's another program that's targeting this domain that's had the amount of research on it. I just don't want to create the impression that it's like, this is it and everybody should just do this type of thing. In all seriousness, I'm happy to communicate with you and talk with you about how to get your team trained up if you wanted to. The end game here, in case anybody's interested, but it's a little bit boring, is because I struggled so much over the last 6 months or so with how do you make sure people do the thing, like the treatment that you create, that you put so much effort into, in a way that doesn't like change it so much that it's not that thing anymore. Okay, because that's part of the voltage drop that I talked about. And so what we're going to do is have the book published, but then when I do, if like, let's just say you had your state voc rehab wanted to get the training, then we could do that training virtually, and then they could get a discount on the books. That's probably not the question you were asking. Punchline is happy to do the training, happy to share materials with you until they get me under contract, and then they're going to say you can't share it anymore.
We're going.
Yeah.
Yeah. Another question is, what role does ABA play
Mm.
in giving individuals with autism tools to lead a good quality of life?
Ooh, all right. So this, the population that I'm talking about here is often not the top population that you think of for ABA, not because of where they're functioning, but because of their age. Most of the people that we have seen have a history with ABA. And I get all sorts of reports, positive, negative, and everything in between. Okay, so it's not like, I don't think every adult on the spectrum is down on ABA. Is this based in ABA? Absolutely not. Absolutely not. At its fundamentals, it's cognitive behavioral therapy. If that's the question.
Other questions here, you guys?
Yeah.
Let me go.
I think you kind of touched on this earlier, but my question is, how many individuals in like the STEPS program would you like estimate like have autism and ADHD? And then also, does that at all affect how, was the approach of the program for those who have?
That is such a good question. So thoughtful. So co-occurrence of ADHD in people who received STEPS, right? 19 of 22 in that OR trial had criteria, full criteria for ADHD. Okay. So just to give you a sense of this, of like, yeah, this is a population that this also experienced a lot of pharmacological treatment, not just for ADHD. But and also I don't want to give the impression that ADHD is the only thing on the table. This is a group who has a very high number of anxiety disorders. I think it's just under ADHD, if I'm remembering right. And a lot of times I feel like in the self-regulation domain, sometimes it's like, as a clinician, is this autism or is this ADHD? But I feel like the older I get, the less I worry about the label. And it's more like, this is the thing that you're struggling with. Let's target the process and not worry about if it's called ADHD.
Sheila?
I'm just gonna make a maybe add the ABA question in what might be a helpful way, hopefully. I think one of the challenges I see with ABA is there are a million things that are called ABA, but to say that you ABA very different things, and it's really hard to know the person that actually. But one, and I know there's so much controversy over ABA, but when I've seen it being used really well, one positive thing I've seen is ABA and helping them do some of the things. Let's go to the grocery store together, let's go to the DMV together, like I've seen it. And I don't even know if that's like really even falls under the traditional ABA umbrella, but like I've seen people who call ABA and so if somebody was asking what was the goal of ABA, it seems to me like we can never have too much practice and too much support for things if somebody has access to that type of, which I think we do through regional support. My guess is that could be really complicated.
I'm so glad that you brought that up. This person in the audience, it feels weird to do the Zoom in person. What? Shula, thank you. Shula, who's here in person, was elaborating on the ABA part and basically how somebody who's got basically a tech or somebody in that domain might be useful, especially for the immersions. And it just triggered me, and this is the last thing I'll say, because I have had a couple of my providers in the recent R34 and the OR trial basically say, one of the holdups here is it's hard for me as a psychologist to like leave my office because of my caseload and do these things. But what I'd like to do is bring on some behavior techs to do the immersions and support me. So I think that actually could be a really reasonable approach. So thank you.
Bill for this,
Yeah.
whereas as a psychologist, it gets much more complicated, and if you're billing not on insurance, it can get extraordinarily expensive. But it is, I mean, my team is doing it all the time, but it's because they don't have to generate money.
Yeah.
It's not.
There's that. Thank you all. I really appreciate this.